you so much for the introduction, and it is truly a pleasure to be here. As Dr. Nelson mentioned, I'm a perinatal psychiatrist. I've been working in the area of maternal mental health and substance use disorders for about 10 years. And it's only until recently that we've really gained a lot of traction in this area, and people like you recognizing the importance of this area and really just how essentially maternal mental health and substance use disorder really is fitting into women's health, and that being a really important component of health overall for women and children. So I'm here to talk about screening and diagnosis and treatment of postpartum depression. If anybody here has any burning questions or anything like that, feel free to interrupt me as we go along. I'm fine with kind of going off track from this talk, but this is what we kind of talked about, and happy to and stick to the agenda if that is what people want to hear about. Am I pointing this the wrong way? There we go. I do want to disclose that I have been working with Sage Therapeutics as an advisor since about 2017, and currently serve on their Speakers Bureau for the first FDA-approved treatment for postpartum depression. Again, this is just an overview of what we're going to talk about today, just in terms of screening, diagnosis and treatment, and best practices. And I'm going to share a little bit with you with what we've been doing, some of the newer work to try to improve overall practices. So as most people probably know, every organization at this point is recommending that we are screening all pregnant and postpartum women for certainly depression, but also mental health problems, some substance use disorders. Your organization in particular recommends that we're screening for anxiety and depression at least once during the perinatal period using validated standardized rating scales. They also recommend that during that comprehensive visit in the postpartum period, at least before 12 weeks postpartum, that we're also doing evaluation of maternal well-being and mental health at that visit as well. So the American Psychiatric Association takes a little bit of a different stance on this. As you would imagine, they would like to see more screening, and actually very early on in pregnancy, and really because we want to pick up if somebody actually has a prior diagnosis of problems, that we can get treatment started earlier as opposed to later. We also recommend screening at the end of pregnancy, and then at every postpartum visit, and at every pediatric visit in that postpartum period. So at the pediatrician's office, 1 month, 2 months, 4 months, and 6 months. It's a lot of screening that we recommend. And the reason is, and I'm kind of going to get into this into more detail, because I think it's really important to understand why are we investing so much effort into this. And it's a really big ask, right? So, if you're an OBGYN, you're doing 2 specialties. You're medical, you're surgical. You're doing primary care, you're doing subspecialty care. And now we're asking you to do mental health care. I mean, that I think is a really unrealistic expectation in a lot of ways. So I think first it's important to understand why is this ask out there, and then provide people with the tools that they need to make this happen. Because if you screen, you are doing way more than screening. You actually need to set up a care pathway so that you're appropriately diagnosing and getting people to appropriate care. So why are we doing this? We're doing this because 1 in 7 women will experience depression during the peripartum period. In low-income women, it's 1 in 3. Anxiety disorders, really, really common in this population, as I'm sure you've all seen, about 1 in 5 women. Those that screen positive for depressive symptoms in that early postpartum period, almost half of them are going to continue to have depressive symptoms a year out. So this isn't just a blip in time, this is a chronic problem where people have persistent symptoms. These symptoms have a really, really negative impact, not only on women and women's health, but they also negatively impact relationships. So women are much more likely to have problems with their partners that have postpartum depression. The partners are also more likely to be depressed if they're depressed. We know that suicide is one of the leading causes of death for postpartum women, so just a very high morbidity and mortality associated with this disease. If you're experiencing depression in pregnancy, we know that there's some obstetrical risks in terms of preterm birth and low birth weight. And then in the postpartum period, the impact of maternal depression on child development is immense. So this is just kind of a amalgam of a number of studies that have been done over the past probably 10 years, but really more past 5 years, where we have these large prospective studies where we can do really good assessments of mom and baby over time and kind of accounting for all those factors that could potentially influence child development. And we still see that children of moms with postpartum depression, in comparison to those without, much more likely to have impaired mother-infant bonding. We see delays in developmental milestones. We see more emotional conduct, behavioral problems in those kids, as well as psychological difficulties when they get into adolescence. Just to give you a sense of the magnitude of this impact, so this was a study where they looked at moderate to severe symptoms of pregnant women in that postpartum year, and they saw that children of moms with those symptoms were 4 times more likely to have behavioral problems when they were 3 to 4 years old, 2 times more likely to have academic problems in middle school, and about 7 times more likely to have depression as adolescents, even when you control for maternal psychiatric illness and history of that. So as you can see, just a really huge impact on mom and child development. So recently, back in February, the U.S. Preventative Services Task Force reviewed the literature on using preventative interventions such as cognitive behavioral therapy or interpersonal psychotherapy to try to reduce the risk of depression in those women that were high risk for postpartum depression. And what it showed is that we actually can reduce the risk of postpartum depression in these high-risk women by using these interventions, which makes a whole lot of sense, right? If you have a high-risk population, you know I can anticipate in this period of time, 1 in 5, 1 in 7 of you are going to develop this problem. If I can prevent this and all the subsequent morbidity and mortality, that's what we should be doing. So who's at risk? The main people that are at risk are those that have a history of this disease in terms of just history of depression, mental health problems, stressful life events, and few social supports. I probably just described 100% of your patients. I recognize that. And so it's difficult to do these interventions with everybody, but if we're doing it just even on some women, that would have a huge impact. If you remember any risk factor and kind of like, the best investment on screening is probably asking about a history of depression. Because if a woman has a history of depression, she is 20 times more likely to develop postpartum depression in comparison to those without. So that was just one factor that I would screen on for high risk and see what we can do for preventative interventions. So some good news is that we have really well-validated screening scales for postpartum depression. People are probably familiar with an Edinburgh postnatal depression scale. This is just a 10-item scale. It's self-report. If you're using this scale, what I would do is make sure you're reviewing item 10 on this scale. That's assessing for suicide ideation. Just be careful of the reverse scoring in this scale, and using cutoff scores for kind of who it is that you are going to further assess. A cutoff score of 13 is actually a decent cutoff score, but even when you lower that down to a cutoff score of 10, about 20% of those people also screen positive for suicide ideation, so you're still picking up pretty substantial psychopathology when you lower that cutoff score. If someone's hovering between 10 and 13, I would just reassess them in 2 weeks at least. I threw the patient health questionnaire in there because a lot of healthcare systems already have this scale. Sometimes in their EHR, it's already integrated in places like primary care. It's a well-validated screener for peripartum depression. I like this scale because if you don't know the DSM criteria, these are them right there. This is the 9 items that we actually use to make a diagnosis of depression. So you add up all these items and you basically look to see if these symptoms are impacting people's functioning. Cutoff score of 10 is a good cutoff score. It has a very high sensitivity and specificity for a clinician-rated or clinician diagnosis of depression. What I also like about this scale is that when you add up the score, you essentially have severity of symptoms. The severity of symptoms map right onto what you should be doing for treatment. So just clinically, really useful tool, tells us what we should be doing for treatment. So you've completed your screening, you've decided where you're going to do your cutoff score, you then have to move on to assessment and diagnosis. So screening is just one point. The next point is we got to figure out what's going on here. So in terms of depression and diagnosing peripartum depression, one of the challenges is that this is a really heterogeneous diagnosis or disease. People will have a whole host of different symptoms, and they'll all both make criteria for depression. So the major things that I look for is a shift in someone's mood in terms of and it's not just like I'm having a few bad days. It's most of the day, nearly every day, for at least 2 weeks, my mood is either sad, I feel hopeless, I feel overwhelmed, I feel anxious, I feel irritable. And that's, again, most of the day, nearly every day. You'll also hear women talk about just not being interested in anything or getting pleasure out of things that they used to enjoy. There's a lot of kind of excessive guilt. That's just a part of depression, and just a lot of self-doubt, often around being a mom, and just feelings of less self-worth. You'll also have people start avoiding family, friends. They're kind of just withdrawing, just wanting to be by themselves. So that's kind of a very common picture in terms of the mood disturbances. Some of the somatic changes in terms of appetite and weight, those you can look at those, but it's hard to sometimes decipher, well, is this just normal physiological changes in the postpartum period versus depression? So I usually kind of go for the other items first. Same with sleep. That is one of those ones that, I expect that to be disrupted in the postpartum period. But when you hear women talking about, I'm exhausted, I lie down to go to sleep, and I can't sleep. I can't sleep because these thoughts keep popping into my mind. I'm anxious. I got to go check on the baby. That's more in line with depression than sleep disturbance in the postpartum period that you would expect. So the most important thing out of all of this, I mean, every single one of us has had every single one of these symptoms on some days. But what you're really looking for is these symptoms are impairing my functioning. I'm not able to take care of myself. I'm not able to take care of my baby. My relationships are being impacted, whether it's family, friends, baby, whatever is going on. But these symptoms have to impact functioning in order for it to be a diagnosis of depression or postpartum depression. You just want to differentiate postpartum depression from baby blues. And that's really easy to do because baby blues are very specific in terms of their onset and their duration and their severity. So baby blues, really common. You'll see that kind of immediately after birth, within those first few days. It should not last more than 2 weeks following birth. And the symptoms are not very severe. So yeah, they don't feel great. Women are a little bit labile, they're tearful, don't feel wonderful, but these symptoms are not impairing my functioning. They're not impairing my ability to take care of myself or others or baby. Whereas depression, on the other hand, is really, we say this can happen in pregnancy or the postpartum year, and it's much more severe. As I've kind of mentioned, it's affecting functioning in a big way. So this is something I see people do a lot. I'll have a resident come into me, they'll list like all of the symptoms a woman is having. It's clear-cut depression, but they'll say, but look at what's going on in her life. And there's all these horrendous things that we hear about all the time going on in people's lives, right? And they'll say, well, then I think this is situational depression. Please don't ever do that. Depression is depression if it's depression, right? So you would never say, wow, this guy has a huge mass in his lungs, biopsy's positive for lung cancer, but, he's been smoking for 20 years, right? Like this, we're still going to call it lung cancer and we're still going to treat it, right? So the situation is really important, and we're going to address those psychosocial problems, but there's no such thing as situational depression. It's depression, and you treat it. One kind of thing that I think is really challenging for providers, and it's challenging for psychiatrists too, is just making sure this isn't bipolar disorder. This is one of those diagnoses it's difficult to make accurately. About 20%, the most recent study is about 20% of women that screened positive for depression in that postpartum period actually had bipolar disorder, not just depression. And that has really important implications for how you treat this, because if you prescribe an antidepressant to somebody who has bipolar disorder, you can actually make it worse, but you are definitely not going to make it better. So we really try to rule this out. What we're looking for is a time in their life where they had at least 4 to 7 days where their mood was either euphoric, and when I say euphoric, it's better than good. It is, I am on top of the world, I can do anything, I can accomplish everything. They feel that way most of the day, nearly every day, at least for 4 to 7 days. Or they're really irritable, and not just a little bit of irritability. Like, I'm in the checkout line with this person and I just want to start yelling and screaming at them, and I might actually do that. So just super, super irritable. Then you start looking for the other symptoms. If their main symptom is irritability, you're looking for 4 other symptoms. If their main symptom is euphoria, you only need 3 other symptoms. And you just see a big change in their kind of self-esteem. They're actually pretty grandiose in some ways. They'll tell you, I don't need to sleep. I could go 1 hour of sleep and I'm fine, 2 hours of sleep, don't need it. I have tons of energy, I can keep going. They talk really fast, very pressured, they're distractible. They'll start all these different projects and get none of them done. Or they'll start engaging in some pleasurable activities that have high risk. So they're either spending a lot of money, they might have sexual indiscretions, driving their car really, really fast, those sorts of things. And it's really just a shift from who they usually are. So you want to rule out bipolar disorder if possible. And then what you're doing is you're getting a sense of, if they have this diagnosis, how severe are their symptoms. So if they're moderate, if they're mild to moderate, so kind of on the lower spectrum, your first line treatment is going to be psychotherapy. So cognitive behavioral therapy, interpersonal psychotherapy, that are 2 evidence-based treatments. These are really effective at treating mild to moderate symptoms and should be first line. I always talk with women about kind of lifestyle factors. It's really interesting when you ask people about their diet and exercise and kind of what people are doing. So really just having a stable base of making sure people are actually drinking water and eating appropriately throughout the day. And we also really target their sleep. So if somebody has, say they're sleeping 8 hours a day, but it's all disrupted, that does absolutely no good to actually restore sleep. You want to see someone that has a 4 to 5 to 6 hour kind of consecutive hours of sleep. That's the sort of sleep that's restorative. And I imagine there's a lot of OBGYNs in the room going, oh my God, I haven't had that sort of restorative sleep in like a decade. But it's true, it's really important, especially if you have a mood disorder, you need to get that sleep stabilized. We often talk about with women shift sleeping. So you take this part of the night, get your 5-6 hours, then you're on, your husband or your partner is taking the next 6 hours. Or actually that would allow her to sleep all night. The vice versa is what I meant. But the former works too. So once someone starts getting into more moderate or severe symptoms, then you're talking about antidepressants and you're thinking about adding that onto psychotherapy. The antidepressants that I'll talk about, our standard of care has always been SSRIs. That's usually first line. We now have a new medication, Brexton, that has a place in this overall treatment as well, and I'll talk about both of those. So when people talk about the very, very common question that I'll get is, what's the safest antidepressant in pregnancy or in breastfeeding? And that's really not the best question. The best question is, what's the medication that has worked the best in the past for this woman? Because I don't want to start something brand new and have a risk that it's not going to work, which there is a high risk that it's not going to work, and it's going to take me 6 to 8 weeks to find that out. So if I got a med that I know is going to work well for this person, barring kind of any major problems with that in pregnancy or breastfeeding, I'm going to use that. If there's no history of any prior antidepressant, we often reach to Zoloft or sertraline. That's not everybody's first line, but it's a lot of first line in that it's a great treatment for depression, it's a great treatment for multiple anxiety disorders, and it's compatible with breastfeeding. So we often reach to that medication a whole bunch. If women are anxious, if they have that kind of depression that has that heightened anxiety with it, I always start at 25 milligrams of this med, and really because if you start right away at 50, you will actually worsen their anxiety. They get a little bit agitated, a little bit, it's almost like they had an extra cup of caffeine in the morning and they feel kind of bad. There are some people that are even more sensitive to that effect of those medications, and I'll start them at 12.5. But really with the idea that within a week, I'm getting them to 50 milligrams. So I talked about some of the common side effects. One thing that you have to mention and kind of think about in the back of your mind is that if somebody is 24 years old or younger, with these SSRIs, there is an increased risk of suicidal ideation. So increased thoughts of suicide. Really important to just tell the people, this may happen, it may not, but if it does, let me know and stop the medication. So one of the things that I've just, in terms of you've started treatment, what do we do from there in terms of monitoring? Hopefully, ideally, people are coming back for weekly therapy. For medication management, I want to see them at least 2 weeks later from starting that medication. and I want people to monitor their mood. So every single day, scale of 1 to 10, where is your mood? Because you're coming in, if you come in 2 weeks later, your report of what your mood is pretty meaningless. And we've learned this a lot just through research and having people do daily ratings of their mood. What people will report their mood is, and then when you go and look at their data, it's totally different. So this is a Mood 24/7 online program. It's free. We often enroll, if they're not in our studies, we're going to enroll them in this. And it essentially, people get a text message every day, says, tell me what your mood is on the scale of 1 to 10. And then when they come in the office, you can pull this up. This is actually an example from one of my patients, and I was like, what is going on here? I have no idea. But what we know is that if people monitor their mood, it actually will change their behavior. They will start noticing kind of the proximal events around their mood and things that might be affecting it. So this was a person that when we started to look at the events related to her mood, we basically figured out that she didn't, this is honestly, so I was like, you don't need a new SSRI, you need a new job. I mean, that is really what needs to happen here. So it's really, really helpful for figuring this stuff out. So I'll touch briefly on Brexton. Again, this is an FDA-approved treatment for postpartum depression. This is for women who are less than or equal to 6 months postpartum. They've had an onset of depression towards the end of pregnancy or in those first 4 weeks following delivery. The medication carries a black box warning because of loss of consciousness that occurred in about 3 to 5% of participants in their safety data. Because of that, there is something called a Zilresal REMS, Risk Evaluation Mitigation Strategy. People know this. The FDA has mandated that people are enrolled in this, so we are monitoring women who are getting this treatment and making sure that the effects of this drug are not any more worrisome than this. Women need to come into a healthcare facility to get this treatment. It's a 60-hour IV infusion. They get monitored every 2 hours in terms of sedation. They have to have constant pulse oximetry through the treatment, and moms cannot be primary caregiver of a child during that time. Breastfeeding is really a discretion of patient and provider. I'm happy to talk about that data if anyone is interested. So we don't know the true mechanism of action of this new drug. We know that brexanolone contains allopregnanolone. Allopregnanolone is one of those neurosteroids that's been implicated in mood disorders, and particularly for women that have menstrual cycle-related mood disorders. And so we actually, allopregnanolone is that hormone that is actually working on the GABA receptor. The GABA receptors, this is our main CNS depressant neurotransmitter system. So as you can imagine, if you're having a drug that's working on that system, you're going to have somnolence, you're going to have sedation, and the loss of consciousness is related to that. It's not like a hemodynamic instability or something like that. It's that you actually have hit on this receptor a little too much, and this person is sleeping and out. In the studies where they had those 5 cases of loss of consciousness, they stopped the drug, they woke up in about 15 minutes, were back to themselves in about 60 minutes. There are 2 studies that allowed for FDA approval of this drug. Sorry, I thought I changed these slides this morning, but anyway, don't look at those numbers too closely. I'll tell you what the story is. So two studies. Study 1 was women with severe postpartum depression. They randomized them to 3 different treatment arms. It's actually 90 micrograms, not milligrams, 90 micrograms per kilogram per hour versus 60 micrograms per kilogram per hour or placebo. In the second study, they actually got 90 micrograms per kilogram per hour versus placebo, and those are people with moderate postpartum depression. The primary endpoint was looking at the change in what we call HAM-D. It's the Hamilton Depression Rating Scale, really common rating scale to be used in clinical trials for depression, and the primary endpoint was after the 60-hour infusion, so when that stopped. And then they also looked at these women, secondary endpoint was 30 days out. So what this shows, the study on top is the one with 3 arms, study on the bottom, 2 arms. The y-axis is the change in Hamilton Depression Rating Scale. The x-axis is time. The dotted line is at the end of the infusion. Sorry if you're colorblind, but the green is actually placebo, and then the other colors are the active treatment. And what you can see is that there is a significantly greater change in or reduction in HAM-D symptoms or items in those that got active treatment in comparison to those with placebo. This is when they combined the 90 microgram data from study 1 and 2. Again, significant reduction in symptoms in comparison to placebo at the end of infusion and still at 30 days out. So I've mentioned loss of consciousness as the most worrisome side effect. The most common side effects with this drug: headache, dizziness, and somnolence, as you would expect. So the good thing, in my opinion, about this medication is that we get a significant reduction in depressive symptoms in days. It typically takes me 6 to 8 weeks to get somebody fully better. So this is a big deal for us, and these women continue to do well at 30 days out. So that's pretty exciting. I do think that however, there are major limitations to these data and to this drug. The first one is that there was an enormous placebo response. I don't know if you all saw that, but it's pretty consistent with clinical trials in major depression to have about a 30% placebo response. Their placebo response was a little bit greater. I think a lot of that has to do with the fact that you had enough social supports to rally around this woman to get her into the hospital, someone to obviously take care of the baby. You go into the hospital, people are taking care of you, and you get 2 nights of sleep. Like, that is like the best intervention for any postpartum mom ever, and we should just do that. So I think that really contributed to the placebo response as well. But even with that, the drug does separate out as beneficial. The mean difference in the depression score in the HAM-D is pretty small, so on average about 2.5 to 5.5 points. That actually is clinically meaningful, and it's actually consistent with most depression studies. The biggest downside to this medication that I see is that this is not going to be accessible to a lot of women. It takes a lot to get into a healthcare facility. It takes a lot to find one that would actually admit these women and be able to do this. And finding childcare during that time is going to be a challenge. But I think it does have a really important role for some women. How am I doing on time? Oh, it looks pretty good. Okay, then I'll talk about this a little bit. What I want to do is transition to some of the things that we are doing in our work right now, really just to see, like, can we improve screening? Can we improve diagnosis? Can we improve treatment? And what these data represent is kind of where we're starting in terms of, if you had all these women that had postpartum depression, we are actually only picking up about 30 to 50% of these women right now. Of those women with depression, we are only getting about less than 20% to treatment, and less than 10% are getting adequate treatment. So there's obviously a lot of room for improvement here. But when you really think about, like, why is this happening, and what is leading to this kind of cascade of lack of treatment, a lot of folks are not screening, and I understand why. I mean, I would be a little bit hesitant to screen too if I didn't have a care pathway for this population. So a lot of people don't feel comfortable doing an assessment or a diagnosis, or maybe they do feel comfortable doing that, but they have no place to send these women if they are actually having a problem. Or maybe they have a place to send them, but it's 3 months until you could get them into treatment, right? Or say you have accessible treatment, women can get in 3 months or however long, but women don't want to go. I mean, women don't want to go see a psychiatrist, and I don't blame them. I'm fine with that. But it's really, there's a lot of stigma associated with this illness, and people don't want to go to treatment. So here are our barriers. Does anyone have any other barriers that you would add to this list? Did we capture most of them? Okay. I'd be really curious if there are, because I would love to think through those. So this is kind of what we came up with and we're piloting in our clinics right now, is basically using technology to better screen, better assess, and get women to treatment. So women essentially are enrolled in the screening program onto their mobile phone. It doesn't require a fancy phone, SMS text-based, so literally your flip phone will work with this. Women actually just complete a brief screening on their phone. That data goes into an algorithm along with data we can pull from the EHR. You don't have to pull that data, but together it makes a nice algorithm to put people into these risk categories. So we have low risk, we have people that have risk factors for depression, and then their care pathway is going to be prevention. We have people who are currently depressed, their care pathway is going to be treatment. Substance abuse risk, obviously assessment and figuring out what's going on, and domestic violence risk. So we get our screening, we get our risk categories. On the other end of the screening and looking at these risk categories is our care coordinator. Our care coordinator is then reaching out to these patients via text, via phone, via FaceTime, however they want to answer their phone, and doing kind of a full assessment, really understanding what's going on, not just kind of mental health needs, but also psychosocial, looking at social determinants of health, really kind of understanding what's the needs and stressors of this population, and getting them the resources that they need, whether it's community resources, whether it's actually mental health treatment. We can do this in a lot of different ways. We're really fortunate to have telemedicine. We also, to obstetric practices, but then we also do direct to consumer. So mom can be sitting at home. We can do, it's essentially a FaceTime, but HIPAA compliant FaceTime that we can do with them. All the data that we gather and what we're doing with these women in terms of care coordination actually gets populated into a note that we can just upload or fax to the provider. So they just stick that in their EHR and know what's actually going on with these women. People can be enrolled in the system at any point. They can do it prenatal care, they can do it at delivery, they can do it postnatally at their well-child visits, wherever. They can enroll at any point. The way that we enroll women, and we say, essentially this is the way our clinic screens for behavioral health problems. These are really, really common. They have a really negative impact on you and your family. The standard of care is to monitor these symptoms just in the same way we monitor blood pressure and we monitor glucose. This is no different. We are just monitoring these symptoms, and our care coordinator is going to be reaching out to you to assist with any needs. So, this is essentially where as soon as we put people in the system, which takes 2 seconds, they immediately get a text message on their phone, and so we can walk them through that screening if they have any technical problems. So they are screened if they come in their first prenatal visit. That's the start of it. They can get screened 2 more times during pregnancy. At delivery, we're not doing delivery, 1 month postpartum, and then every 3 months until 18 months postpartum. 18 months postpartum, why do we do this? I have an 8 and 10-year-old, and I still feel postpartum some days. So, I would screen these women forever. But I really feel like those first couple of years are very critical, particularly around mental health. So I just want to acknowledge, I work with just an amazing, amazing group of people at MUSC. I'm really fortunate. And so these are them. These are some of my funding sources. And I'm happy to take questions and talk whatever it is that you guys want to talk about.
Any questions? Raise your hand and we'll come to you.
Did I talk really fast?
So great talk. I was just wondering if you can comment a little on kind of access to and cost with Brexanolone.
Yes, definitely. So I think we've talked about the access issues. The concerns are having to find a healthcare facility that delivers this, being able to get in there and have 3 days off. The cost of the medication, this is a brand new FDA-approved treatment. It is costly. I think it's going to probably on average cost somewhere between $20,000 and $25,000 for the overall infusion. And that sounds like a lot of money, right? When I think about other places in medicine where we do IV infusions for cancer, we do that for other diseases, I don't see the same sort of the cost is sometimes the same or more. I don't see people having a problem with that. So it's kind of curious to me why we're having a problem here. The other thing that I would say about cost is that maternal mental health and effect on child development is hugely costly, right? We are transmitting effects of a disease across a generation. So if I can get that person treatment and get them better quickly, I'm going to do that. And I think it's worth the cost at this point. That's my thoughts on things.
Hi, thank you for this talk. I think a big limitation for me is, I agree, I get a lot of patients coming from their pediatrician's office, where they recognize that they have depression, and then they show up at my office and said, pediatrician told me I should talk to you. And then often I agree, yes, you are depressed, I think they need counseling, I think they need medication. I'll often start them on Zoloft, but, I don't feel like they're getting that follow-up care. I don't have a ready reference to send them to. Is that program that you mentioned available to us? That
Well-
online program?
The one where I was talking about this text-based screening?
Yes.
So we should really think about that. So because it's, you guys are in a different state, so it's available to people in my state because I have a license to practice in that state. But we should really think about, is there a way to set that up in another state and get our providers with a medical license in your state? Or is there a way to provide what we call telementoring, so ECHO sort of model, where we can get people that are doing some of this work, the support that they need to do this work well, right? So just, nationally, there is a huge problem with access to mental health treatment, right? Everybody is struggling with this. One of the things that I've really have enjoyed doing in my state is working with different healthcare systems and OBGYN practices to go in and say, look, this is the ideal model, right? What are the resources that we have and what can we put together? And so there's a lot of different creative ways to do that. If it's something that you would want to work on, I'm more than happy to talk with you. I'd love to think about how we could do, it sounds like from what I was hearing from Dr. Hawk and Dr. Nelson is that your area is really lacking in that, and it's not uncommon, it's everywhere. So maybe we can think about some creative ways to support you guys. I would be happy to do that.
But as far as you know, there's no comparable program like that here.
You mean the text-based screening thing? I don't think so.
No.
I don't know of other people doing that.
Thank you so much.
Sure, and maybe we can do it. It's easier to do things across state lines if you do it in the context of research, so maybe we could do a little study and be okay with that.